Hi, welcome back. Thank you for coming back and just watching what I'm doing on this channel of ECA to Student Paramedic and beyond, I hope. If you don't know me, my name is Freyja and I work out of Christchurch, and I'm currently a student paramedic about to start my third year in January next year. So I have not had any time to do any more videos the last 3 weeks or so, primarily because all the jobs I've done so far I've actually mentioned on videos in the past, and I didn't want to bore you having the same sort of videos again and again. However, the one of the videos I would like to do today is about the necessity of very good history taking. And now, history taking when you are going to a patient's house to try and figure out what's going on with them is important, because you need to have an idea of what happened beforehand in order for this patient to be in the situation they are at the moment. Now, my prime example is I went to a lady who came up on the MDT on the computer on the ambulance, saying that this lady was having a headache and she was feeling unwell. And you know, sadly, we look at things like this and we go, oh dear, someone's got a headache, why can't they go to the doctor, why can't they do this, why can't they do that? And we've got all these preconceived ideas. And it came as a Cat 3, so it was not like a life-threatening emergency, but we're still having a Cat 3, so we're still going there with the ambulance. So we got to this lady, and again, as normal, we're doing our primary survey, we're doing our patient triangle before we go in, as it were, our scene safety situation. It's all going through your mind. You don't actually say it out loud, but you're just checking everything first of all. And this lady was sort of middle-aged, and she looked like she was in a bit of pain, but not terribly. You know, she was sat down, she was very responsive to us as normal, she was talking, and so my first thing was I generally hold on to the wrist and have a feel, obviously with her consent, have a feel of her pulse at her wrist, which gives me lots of different indications of different things that's going on her. It could be that I'm checking the rate of the pulse, I'm checking how strong it is, I'm checking to see if it's missing any beats, like an AF, and I'm checking to see how warm the hands are, if they're cold, if there's any circulatory problems, all these things. I'm and having a look at the nails, and you know, just checking just generally with just that one little touch there. And she seemed fine. She seemed, but apart from this headache. So I tried to get some history about, you know, what happened today. She woke up in the morning, her headache was not so good. She tried taking paracetamol. That hadn't actually done any difference. She's, since the last day or two, she's been off her food. She's been feeling nausea but not sick. You know, she's not had any pain anywhere apart from her head. And she thinks that her eyes felt a bit different as well, but nothing major, though she does wear glasses. So I was thinking, okay, well, let's go through some obs and see what we come up with. So her SATs were good. She had a really good blood pressure, so nothing wrong with there. You know, I checked her breathing and her respiratory systems, all clear, bilateral rise and fall, all that. I checked that she had a good temperature, and she didn't have any sugars, which of any note to worry about. So I was like, okay, so we were thinking, I was talking to my colleague, and I thought, well, you know, maybe just coming down with something, but something was niggling me, and I wasn't really happy to just say to her, well, you know, have you talked to your doctor and got more tablets, which she had talked to the doctor or tried to talk to the doctor. But, you know, currently with this situation, it's difficult to get hold of doctors, and she didn't want to hold on for another hour waiting for the doctor's surgery to open up and to talk to her. So I prodded more, and I said to her, okay, so you felt this way for 2 days. Okay, so anything's changed? Have you eaten anything different? Have you gone anywhere different? Have you, you know, I was just trying to sort of grab at straws. Have you slept differently? What could have caused this problem with her headache? Do you suffer from migraines normally? You know, sometimes people suffer from migraines. Have you fallen at all? Thinking back of the head could be having a headache, but then I thought that it was only, you know, yesterday that she started having these headaches. And she said, funny you should say that. A week ago, she had a child with her who ran at her without her realising and basically made her fall backwards. And she bumped her head on the back of her head as she went down. I thought, now this is different. This is something that could be worth investigating further. Okay, so did you lose consciousness at that point? No, she didn't. Okay. Did you get a headache at that point? A little one. Was there any other bleeding? Did someone see you happen? Did you go to the doctors, go to the hospital? No, nothing like that. She got up, she felt a bit sort of woozy, but she was fine. And then all the way through the week, she was absolutely fine until 2 days ago. So looking at this further, my cogs were going in my head, which is very unusual because they don't go very well. And I was thinking, I'm wondering if she's got a delayed onset of concussion. And below me, it was correct. She's actually has concussion. Now, remember, concussion doesn't always appear straight away. You don't always get the nausea, the becoming unconscious, or the headaches, or the visual disturbances, and other factors. You don't always get them all at once, all at the same time. They can come at different times. In fact, concussion can come and hit you on the nose, as it were, within weeks, even months further on down the road from the time of the onset of what happened. So keep in your mind that it's possible that symptoms can arise further along the line in history than the actual time it actually happened. So yes, we took the lady down to the hospital in the end, and yeah, fair enough, she was diagnosed with concussion, delayed concussion. So I was really happy with that diagnosis, even though we don't diagnose, or in that sense, it's always good to know, have an idea of what it could be, and to try to get some specialist help with that. The other thing I had was, I had a lady who, in around 85 or so years of age, she had activated her falls detector, which is a little pendant. So she falls, it goes off, and the carers or family members, whoever's connected to it, knows straight away that she's fallen. So by the time we got to the patient's house, her carers had already got her on a chair. Now, this poor lady, sadly, had dementia. So this lady's dementia was quite advanced, because every time I asked her a question, she wouldn't remember. And every 30 seconds or so, she kept on asking, where am I here? What am I doing here? Why are you here? I'm okay. What are you doing here? Why am I sat on this chair? And I kept on saying to her, because we got called out, because you had fallen on the floor, your carers have picked you up, and now we're making sure that you're okay. And she would accept that. But then 30 seconds down the line, who are you? Why are you here? Why are you being called out? And it became almost like a circulatory question and answers. And it kind of overwhelmed me a bit, where I was trying to do my obs and trying to get a history of what's going on with this lady. But because of all the questioning, I was losing my track, I was losing my path of what I wanted to do next. And the most important thing at that time was that I actually forgot for a moment that if you've got a query collapse fall, what's the thing you need to do? It is an ECG. We must make sure that the reason for the query collapse fall isn't because of any cardiac changes. She may have had a cardiac event, she may have had a stroke, we don't know. But that came out of my brain as a possibility, because of all the questions that she was bombarding me, and I had to repeat myself from the very beginning to the very end again until I had to repeat myself again. Now, what happened was, in the end, yes, we sorted her out. We did her obs. We got the information from the carers and from her medical records, and we basically took her in because it was an unwitnessed fall or collapse. Even putting the ECG dots on was really tricky because she didn't want it. She didn't want to put anything on her. Every time we touched her, she kept on saying ow, even the very barest touching on the skin. So history was very difficult to get hold of at the time, and actually doing the obs for this poor lady was really quite difficult to do. However, we did do it. And then when we had put her into hospital and handed it over to the doctors and nurses there, my paramedic took to my side and said, right, Freyja, okay, so after a while everything went fine, but you missed quite the important thing about why are we being called out there, because of the coronary collapse fall, okay? And the ECG needs to go on a little bit sooner than, you know, after sort of half an hour of all these questions. So my reflection on that is try and get the history as quick as possible from whatever means as possible. And next time, if someone keeps on asking me, you know, what's happened and is repeating because of the poor dementia they're with, then my answer should be, we're here to give you a checkup, or we are here to make sure you're okay. And don't mention that they were on the floor. Don't mention that they, you know, we're not sure why they fall to the floor, and then the carers have come in and picked them up, and so is coming in to check on them, and the family members are coming in. Don't forget all of that, because with a 30-second to a minute memory loss, they're not going to remember any of that, and it's just a waste of words, really. But to make sure that they are trying to have some understanding what's going on, because being human beings, they have the right to know. Then say something really simple, something that you can repeat very quickly, and that's not going to interfere with your observations, with your history taking. And that simply would be, hi, we're here to just make sure you're okay, or hi, I'm just checking up on you to make sure you're all right. And that's it. You know, you don't have to do anything else. I mean, of course, change it as you need to, because every patient, every situation is different. But unlike me, try and keep it short and sweet for our dementia patients, because it's just easier for them, really, and easier for you to do the obs and in history taking. Right, I'm hoping that's a little bit of help for you, especially for you new ECAs out there. It's always a learning curve, you know, even two years down the line as a student, I'm still learning, and I will always learn. If you've got any comments about that, please keep them cordial and nice, and let me know what your thoughts are and how would you do that situation. It'd be really interesting to try and learn from you guys as well. Right, thanks again for tuning in. I will see you on the next time. Bye bye for now.